Hello, everyone. My name is Shanta Sresta, and along with me, I have Jennifer Kronosky and Ethan Cheng. And for this presentation, we'll be discussing pitfalls in big data analytics for medical use and a coronavirus. So here's the agenda for today. We have a topic slide where we look at the big data question, followed by pitfalls in big data analytics. We'll also be covering three main areas. There are ethical considerations, big data, and the COVID-19 responses and challenges. Then we'll quickly summarize our main points in a conclusion slide, and we'll have the reference slide at the end. The question is, what are the pitfalls of using big data analytics in medicine and its impact on the COVID-19 response? So the first pitfall we're going to look at is the issue of privacy. The question is, does the big data comply with HIPAA rules and regulation? If any organization is using medical data to do research, then it is imperative that it is complying with the Health Insurance Portability and Accountability Act of 1996. Under this rule, patients are entitled to receive notice of privacy practices in plain English on how their information is shared and used. Over the last 2 years, there were many COVID-19 trackers that have been developed to combat the rising COVID-19 cases. Just in South Dakota, the developers of Case 19 app claimed to anonymously collect users' locations, but it was found to have violated its own privacy policy by sharing users' location and data with other third-party apps. So privacy is one of the biggest ethical challenges using the big data because it is critical that the data scientists are mindful of complying with HIPAA's rules and regulations. So the next challenge we're going to focus on is bias in algorithm. The question is, can big data steer clear of hidden racial biases in healthcare? Our research indicated that there were strong hidden algorithmic biases, racial biases in healthcare industry. For instance, a recent article published in Wall Street Journal stated that there was an algorithm that prioritized care for white patients over Black patients despite being sicker. The purpose of the algorithm was to detect patients with highest medical needs or additional care, but the problem was the algorithm used cost metrics to rank patients. And the researchers found that the healthcare spending for Black patients was less than for white patients with similar medical conditions, essentially prioritizing the healthier white patients ahead of the sicker Black patients. People need to understand what data is collected, how it's measured, and its limitations, because the algorithm is only as good as we design them. With that being said, now I will hand the presentation over to Ethan, who's going to talk about big data and the COVID-19 response.
Now I'm talking about the issue in big data about quarantine. Big data is a double-edged sword. The new software to dictate quarantine appeared to send personal data to the public in a troubling precedent for automatic social control. For example, authorities in China are using an app developed by private company to make decisions about who to quarantine and for how long. The app of 700 million users to colors. Green enable a restrictive movement, yellow requires 7 days of quarantine, and the red requires 14 days of quarantine. To enter buildings and move around their neighborhood, people must scan a QR code at a mandated checkout. However, the rule behind the color assignment are secretive, making it difficult for individuals to understand why they will assign a particular color or what circumstance might trigger change a color. The app also collects users' location data and share it with police. Users have complained that the app's decisions are random and difficult to appear. Some of them have been confined to their homes for indefinite period, even after serving the quarantine period mandated by the apps. Another example in Turkey, the health minister mandated people infected with COVID-19 to download an app called Live Feed inside the house as part of the pandemic isolation tracking project. If they leave their homes, those who failed to comply with the warning and continue to violate the quarantine are reported to relevant law enforcement and face administrative measures and sanctions. So the use of big data create a real-time target opportunity, which can be used by government to forcefully enforce quarantine and discriminate or crack down on population for other reasons. Finally, I think medical information is sensitive, and as Shanta discussed, privacy need to be an ethical consideration. Collection of this sensitive data require trust user to protect and safeguard the data. This use many resources and can be very expensive, which lead to the next category of pitfalls challenging. Jennifer will discuss those now.
The first challenge in collection barriers is cost and volume. An important consideration is data volatility. How long should big data be kept before it's considered irrelevant? Is that affected by virus mutations and policy changes? Due to the huge amount of data, volatility must be considered because of storage and usability limitations. Unused data cannot be kept without massive storage or hindered performance. Rapid, cost-effective retrieval is necessary to reach the end user in time for the solutions to be usable. This leads to another challenge in acquiring usable data, self-reporting. Mobile apps aimed at identifying the spread of infection and healthcare consumption and contact tracing are reliant on self-assessment and willingness to report. App trackers rely on people opting into geographic data collection, and smart devices rely on users wearing them consistently. The human element remains a challenge in data collection and efficacy. According to a study on applications of big data analytics, the main challenges of applying data analysis to assist with COVID-19 are the volume and variety of the data. For example, prediction models developed based on data from a particular hospital may not provide the same accuracy when applied to data from a different source. Therefore, sharing data on the local and international levels will serve in improving the accuracy of data analysis. At this scale, data must be anonymized to protect individual information, and if the means to anonymize aren't available, it limits the sharing range. When data is collected, we must consider the next challenge. Reliability and accuracy. The increased use of social media during the pandemic made the platforms an easy outlet for individuals to share their perceptions regarding the virus and its scope. The seemingly endless amounts of data were and are used to track people's views and awareness about policy. This, of course, and unfortunately, is limited to those with access to the platforms. Those with access and high use provided an efficient means to spread information, but unfortunately, it also led to an easy spread of misinformation. So as the infographic shows, machine learning algorithms are helping to filter a lot of bad information, but much of the non-factual information is shared and consumed. Though this may seem like an obvious pitfall, the next challenge was an unexpected consequence. Algorithms aren't immune to force majeure. Existing algorithms used to predict risk, triage, and readmission rates failed under pandemic conditions. These predictions are often used to determine where to use people and assets, but the surge disrupted triage and stretched beyond many hospitals' capabilities. Without the tools or staff to treat, these algorithms became irrelevant. Another factor altering typical results was the dramatic decrease in ER visits, even when emergent care was necessary. As can be seen in the infographic, an alarming percentage of serious time-sensitive medical emergency patients feared seeking care. These cases would have normally been high-priority triage and risk. A truly unintended consequence of risk algorithms was the increase in a higher rate of mortality, diseases, and cancers that would have had a better prognosis with early intervention. To prevent the spread of COVID and allocate resources to treating COVID patients, secondary prevention measures like screening were deemed non-medically necessary, resulting in what we're now seeing as an uptick in cervical and breast cancers that, if caught during annual screening, would have had a better outlook. Standard exams that might have caught abnormalities didn't. This might not be the only unintended outcome that results from the pandemic. We learn more every day as we move towards endemic status. For now, we will conclude. Shashanta discussed our topic and ethical considerations, including privacy and algorithm bias. Ethan discussed the COVID-19 response, including quarantine security and vulnerability. I discussed the challenges of cost, collection, reliability, accuracy, and unintended consequences. Thank you for taking the time to view our presentation. For more resources or details, the next slide contains references used in our presentation.